Lightweight. Pete.
What's going on, bud?
I'm training for a half and my knee, it's all shungad.
What happened?
I don't know, I just started running and it hurts.
We gotta do a deep dive.
Please, man, it's killing me.
Let's do it.
Welcome back to PFP, everyone. Today we're gonna take a deep dive into the knee. First, we're gonna start with anatomy. Now, there's a ton of musculature involved with the knee that's gonna either insert into and or cross the joint. We have our quads, hamstrings, gastroc-soleus, tibialis muscles, abductors, adductors. There's a ton going on in terms of musculature. Now, when looking on the internals, we have cushions like our menisci, our ligaments, ACL, PCL, MCL, LCL. We also have our kneecap, which also plays a vital role in knee health. But that is a zoomed in picture of the knee. We like to zoom out and look at the entire lower extremity. Now, when looking at the hip and ankle, there's a lot of relative motions occurring that's going to affect the motion of the knee. The femur is going to internally rotate. It's going to externally rotate. Similar with the shin bone, you're going to have some internal rotation, external rotation, and all of these motions are going to play a huge role in how the knee is going to be supported and how it's going to feel. Let's take a deeper dive into those principles on the PT table.
Now that we're on the PT table, we're gonna do a deeper dive into some of the special tests that we do and also our PT examination. First thing we're looking at is just how the knee bends and straightens, right? So when it's bending, what's happening in terms of relative motions and rotations, the thigh bone is turning relatively outward and the shin bone is turning relatively inward. So what I do is I'm gonna turn the shin inward as the knee bends to make sure we got that rotation going. And you can see he gets his heel close to his butt. Now in terms of straightening the knee, this thigh bone is gonna turn relatively inward and the shin bone is gonna turn relatively outward. So when I'm checking for extension to get the knee as straight as possible, I'm going to sneak in some of that rotation and see how the knee moves to see if he has that relative motion, that rotation. Other things that we can do in terms of testing the integrity of the ligaments, you can do a simple valgus and varus stress test. A valgus force is anything that's going inward, varus stress is going outward. So here, I'm going to keep the knee straight. I'm going to use my outside hand to push inward. This inside hand is stabilizing. I'm just going to push and look to see if there's any discomfort. Then I'm going to switch my hands to do a varus force. This hand stabilizing, the one on the inside is pushing outward, and see if there's any discomfort. Now when the knee is straight, this is the safer position for the knee to be in. As you bend the knee, it's relatively more loose. So now you can get a better understanding of what's going to happen. So again, I'm going to do the valgus force again. I'm going inward. Good. And then I'm going to go outward. Cool. Now to do this more dynamically, it's called the McMurray's test. What you're going to do, you're going to apply a valgus force inward as you straighten the knee. And look to see if there's any signs of discomfort. Good. Then you go the other way. And again, I'm applying my force outward to see if there's anything going on with the ligaments at the joint. Good. And then one last thing, Chess, you can hop off the table. You can sit right here. A lot of things that happen with runners. You have the quad tendon, you have the patella tendon. These tendons can get aggravated, especially if you're running a ton downhill. So we just want to do a quick isometric of the quad to see if that elicits any pain in the tendon. So my hand's going to be here and chest is just going to kick into my hand. And see if that is producing any tension in this spot or up here. The special test that Pete performed can go under one category of injuries. Now I'm going to go specifically into patella dysfunction. So I'm going to want Pete to sit up on the table and I'm going to look specifically at his patella range of motion. Now I'm going to have both his legs nice and straight. I'm going to ask him to take deep breaths because he doesn't like people touching his patellas. And I'm just going to look how his patella moves in his trochlear groove. He has great gliding, medial to lateral, superior, inferior. Superior is good, inferior is mediocre. Probably because of his quad muscles. He has a very strong quad, most likely tight patella tendon, which is going to
superiorly track his patella. Now, when looking further into special tests, there is something called an Ober's test, which is going to test for IT band syndrome. So you want to put your thumb on the femoral condyle and go into extension. And if there's pain there, that's letting me know that there's some tightness in the IT band, probably caused by the TFL, which is going to compress any structures on the lateral knee, such as the fat pad. This can cause irritation and inflammation. So if you're a runner that has lateral knee pain, could be IT band syndrome caused by a tight TFL. If you have lateral pain and you had a positive McMurray's, could be a meniscal injury. If you have pain on the bottom or top of your patella, could be tightness in your quads, right? There's a lot of things going on that can refer pain to different parts of the knee. Now, one more test to look at the TFL. I'm gonna have Pete roll onto his left side. Okay. I'm going to straighten his knee, bring him into extension. You could straighten this leg for me. Good. Now, in this position, all I wanna do is drop his leg and see if it falls. If it doesn't fall, that's telling me that his TFL is tight. But a lot of patients like to play a little game where they will shift their pelvis this way so that the TFL is no longer on stretch. You want to stabilize that hip, make sure the ASIS is pointing perpendicular to the wall ahead. Drop that hip, drop that leg, and the leg should relax. Now, Pete's gonna do a positive, so you're just gonna hang out up here. If I drop and he's just kind of hanging out here, re-aggravates pain on that lateral side, it's showing me that there's some tightness in that TFL that's possibly causing friction on the lateral side of his knee. And relax. And you can roll back over for me. Good. Relax, relax. If that pain is not lateral, but you still are getting ideas that it has something to do with the patella, you can do a Clark's test. Most likely this is going to aggravate any patient, but what you want to do is apply a downward pressure down towards the ankle of the patella. Pete's going to make a muscle that's probably going to elicit a crunch and pain, and that could show positive signs of either patella dysfunction or chondromalacia. So one last condition I'd like to talk about is a plica syndrome. So that is like a synovial type membrane that you're usually born with that can be irritated with compression or patella dysfunction. So all you would want to do is track the patella medially, go into flexion, and that would theoretically compress the plica, eliciting pain. Now, one last thing that if I wouldn't say, one of my professors would most likely yell at me, but if you have any radiating pain, numbing, tingling at the hip, down the leg, at the knee, it's always important to rule out the hip as well as lumbar radiculopathies.
Based on our PT assessment and the evaluation that we did on the table, we have a good chessboard in terms of what the patient lacks in terms of his or her mobility and relative motions. We can devise a game plan outside in the gym and see that our interventions in and of themselves are diagnostic. They'll also expose those deficits in range of motion, strength, and relative motion as well.
Now, lucky enough, I'm a case study for this video. I do have IT band syndrome, so I have that pain on my lateral knee because I lack external rotation of my tibia. I have tightness in my TFL, leading to patella dysfunction. So I will be proof that our intervention strategies are going to be diagnostic in themselves.
Let's talk some intervention strategies for the knee joint, in particular for runners. This is not an exhaustive list. Obviously, your interventions are going to vary based on the patient presentation, but these are some of the things that are going to benefit Francesco's situation. So the first thing we're going to do is a TFL soft tissue mold. Reason for this, the TFL is a compensatory mover in terms of internal rotation. You want that innominate bone, that hip bone, to be able to turn inward. But if this innominate bone can't turn inward, the TFL is going to be very overactive to take this femur and compensate and try to twist it inward. So in order to get the relative motion of the actual hip bone, you first want to make sure that that muscle is calmed down. So we're going to take that lacrosse ball right on his TFL. So if you find the hip bone, you kind of put your thumb on it, let your finger come through. This is where the TFL is going to sit. And Chesko's just going to sit there. Get a couple of breaths. And if he's a glutton for pain, what he can do, he can take his knee, bring it up to his chest, and then back down. You could tell with the scream, it's kind of painful.
So the next intervention is going to be a side-lying adductor pullback. What this is going to do, theoretically, is gain the inflare of our pelvis that we're missing, causing our TFL to compensate. So what Pete's going to do is lie in a 90-90 position. Foot is going to push against the wall. He's going to pull back his right leg. And in this position, he has a few options. He can just squeeze the block. He can oscillate the block up and down. Or he can just do pullbacks up and down. Very well done. Now, if you want to increase the difficulty ever so slightly, Pete can elevate his leg. It's important to know that in this position, if you feel that TFL cramping, you've gone into too much internal rotation, so lower your foot ever so slightly. Now, again, in this position, Pete can pull back that hip, back and forth. He can pull back and squeeze, hold for about 30 seconds, and he can pull back and oscillate and do that a few times. Well done.
One of the guiding principles here at PFP is proximal orientation dictates distal performance. In our first two interventions, we address what's happening proximally at the hip. Proximally just means things closer to the body. Now we're going to look a little bit distally or further away from the center. We're going to look at the knee joint. Now, Chesko struggles with his shin turning outward, which we know is part of the screw home mechanism. When you're straightening your knee, your femur has to turn inward and your shin bone has to turn outward. So what we can do a banded TKE, a terminal knee extension, while helping him get into those positions. So what we're going to do with his right leg, this is going to come up top. Yep. And this is going to come underneath. So now before he does it, look where the bands are doing. As he's straightening his knee, the band is going to pull his femur into internal rotation. And I'm going to pull more on this side because this is going to really help him get into that external rotation of the shin. And what he's going to do, he's just going to try to straighten his knee. Good. And again, the bands are facilitating him getting into that position.
I could feel the bands pulling my femur inward and my tibia outward.
Good. Two more. Good. Take a break. The next intervention we're going to choose is what we call a toe touch pedaling. So what Chesko's going to do, he's going to put his hands here. And now in this position, he's going to try to keep his knees as straight as he can. He's going to come up on his toe, and he's going to shift into this hip. And then he's going to alternate back and forth. Yep. So what you see here, if you can hold this position, his foot is plantar flex, his calf is working. That's going to relatively externally rotate his shin. But because he shifted into his hip bone is internally rotating, and therefore his femur is internally rotating. This is giving him the relative motion that he lacks. And then as he gets looser, we can bring the yoga blocks down and eventually get him down towards the floor.
One of the final steps in our closed chain progression is adding a Camperini specific to running technique. Personally, this is one of the movements that helped me feel the best because it was so specific to my running form. So if you're thinking about terminal extension when running, you're in this staggered stance, your foot is plantar flexed, and you're in terminal knee extension. So what Pete's gonna do is elevate his heel on this board, have his stance staggered. He's gonna pick up the weight. And now in this position, like I mentioned earlier, he's plantar flexed, which should provide some external rotation of that tibia. He's gonna rotate down towards that foot, which is giving us relative internal rotation of that femur, and he can strengthen and load this position. Now, I always preach gaining control or strength in a controlled environment should help transfer in an uncontrolled environment or when you're out running.
We talked loading, now let's talk plyometrics. We gotta talk force absorption and also force production. First thing we're gonna do, we're going to go into a split squat hop. Good, one more time. Boom, hold this. Look at his right leg. When he's back here, he's in extension, so extension is internal rotation of the hip bone, also the femur. This will relatively externally rotate. He's plantar flex, he's stable here. Now do one more time with your right leg forward. Hop. Here we're working mid stance. So he's pronating his foot. Everything's internally rotated, the tibial tibia will relatively externally rotate in this position because his femur is turning inward and he's pushing into the ground. To take this a step further, what we're going to do, he's going to hop, he's going to split squat drop, maintain this position, then push off that back foot and go. Right, take it slow. You're turning force absorption into force production, but as an athlete, we want to make sure that's short. So as he gets the hang of it, he's going to try to decrease the amount of time that goes from force absorption into force production. Be quick off of it. There we go. That's going to teach his body to absorb force, get the stretch reflex, and then quickly produce force. One more time. Pop, pop, pop. Land, push. Good. In closing, those are just some of the intervention strategies that we use. Others can be incorporated. The biggest thing is use your guiding principles to assess your results that you get in the PT examination, as well as what's going on in terms of the movement of the individual. Then use your guiding principles to reverse engineer the process and find the most effective and efficient solution. Our standard is attention to detail. So if you look here, when Chesko lands in that split squat drop, you can see that front foot, especially on that right side, landing in a supinated position instead of internally rotating at the hip to push into the ground. And this goes hand in hand with what we said earlier, that our interventions are diagnostic in and of themselves. That's one of our guiding principles here at PFP, and that's the highest amount of standard of quality care that we provide. Thank you guys for watching. We'll talk soon.